Hello everyone and welcome back to Wally's nursing videos. Today we're exploring the respiratory system to explore acute lung injury, ALI, and acute respiratory distress syndrome, ARDS, two serious conditions that can lead to respiratory failure. In this video, we'll cover the pathophysiology of ALI and ARDS, nursing assessments and care to prevent complications, risk factors and diagnostic tests, key interventions and medications to support respiratory function. Let's get started with our lesson, Pathophysiology of ALI and ARDS. Let's start by breaking down what happens in ALE and how it can progress to ARDS. Acute lung injury. ALI represents the early stage of lung damage, often due to infections, trauma, or inflammation. When the lung tissue becomes injured, the immune system responds by releasing cytokines and other inflammatory mediators, leading to increased capillary permeability. Damage to the alveolar capillary membrane allows fluid to leak into the alveoli. Fluid accumulation. The fluid within the alveoli prevents effective gas exchange, leading to hypoxemia or low oxygen levels in the blood. Decreased lung compliance. Fluid and cellular debris in the alveoli make the lungs stiff and harder to expand. Key assessment finding for ALI. Patients may exhibit rapid breathing and low oxygen saturation despite oxygen therapy and may report shortness of breath or difficulty breathing. Acute Respiratory Distress Syndrome, ARDS. If ALI worsens, it can lead to ARDS, a severe form of respiratory failure. In ARDS, widespread inflammation damages the alveoli and capillary walls even further. Alveolar collapse. Surfactant production decreases, causing alveoli to collapse, further impeding gas exchange. Hypoxemia becomes refractory, meaning it doesn't improve with oxygen therapy alone. Organ dysfunction may follow as other organs become hypoxic due to low oxygen in the blood. Pathophysiologic stages of ARDS: exudative phase, inflammation and fluid accumulation in alveoli. Proliferative phase, cell repair begins, but fibrous tissue may form. Fibrotic phase, permanent scarring, leading to long-term respiratory issues. Key learning point 1. Recognizing the progression from ALI to ARDS helps you anticipate necessary interventions and prevent complications. Risk factors for ALE and ARDS. Both ALE and ARDS can result from direct lung injuries or from systemic factors. Understanding these risk factors helps us identify high-risk patients early. Direct lung injuries, pneumonia. Infections can directly damage the alveolar capillary membrane. Aspiration. Inhalation of gastric contents or other foreign material can severely irritate lung tissue. Trauma. Direct trauma to the lungs, such as from a car accident or chest injury, increases the risk of ALI. Inhalation of toxins. Exposure to smoke, chemicals, or other toxins can damage the lung tissue. Indirect lung injuries, sepsis. Severe infections can trigger systemic inflammation, affecting the lungs. Pancreatitis. Inflammatory mediators from the pancreas can circulate and damage the lungs. Blood transfusions. Transfusion-related acute lung injury, TRALI, can occur with multiple blood transfusions. Shock. Low blood flow and lung oxygenation can lead to ALI and ARDS. Modifiable risk factors. Central venous catheters. These are associated with infections that could lead to sepsis and ARDS. Smoking and alcohol use. Both can impair lung function and reduce immune response. Malnutrition. Lack of essential nutrients weakens immune defense and repair mechanisms. Chronic illness. Conditions such as diabetes and liver disease may predispose patients to infections and poor immune function. Key learning point 2. Identifying modifiable and non-modifiable risk factors allows you to implement prevention strategies, especially in high-risk patients for ALI and ARDS. Nursing assessments and diagnostic findings for ALE and ARD. Accurate assessment and timely diagnostics are crucial for managing ALI and ARDS. Nursing assessment findings. Increased work of breathing. Patients may use accessory muscles, exhibit nasal flaring, and experience a rapid respiratory rate. Low oxygen saturation. Oxygen saturation often remains low in ARDS despite oxygen therapy. Changes in lung sounds. Crackles or decreased breath sounds due to fluid in the alveoli. Diagnostic tests for ALE and ARDS: chest X-ray, In ARDS, X-rays often show bilateral infiltrates, which resemble a whiteout appearance due to fluid. Arterial blood gases, ABGs. ABGs reveal hypoxemia, or low arterial oxygen levels, and may show respiratory alkalosis in early stages, progressing to respiratory acidosis as the condition worsens. CT scan. More detailed than an X-ray, it can confirm the extent of alveolar damage and fluid accumulation. Laboratory tests. Elevated inflammatory markers, such as C-reactive protein, may indicate systemic inflammation. Lactate levels may increase as tissues experience hypoxia. SOFA score for organ dysfunction. The sequential organ failure assessment, SOFA score, is essential for monitoring organ function. An acute change of more than 2 points in the SOFA score indicates organ dysfunction and necessitates immediate intervention. Key learning point 3. Early identification through assessment and diagnostics allows for timely interventions, potentially slowing disease progression. Nursing interventions and care plan for ALI and ARDS. Nursing care for patients with ALI and ARDS focuses on optimizing oxygenation, preventing complications, and supporting recovery. Optimize oxygenation and ventilation. Mechanical ventilation. Patients with severe ARDS often require mechanical ventilation with low tidal volumes to minimize further lung injury. Prone positioning. Turning patients onto their stomachs improves oxygenation by promoting better lung perfusion. Continuous oxygen monitoring. Use pulse oximetry and arterial blood gases to monitor oxygenation closely. Fluid management. Avoid fluid overload, as excess fluid in the lungs can worsen hypoxemia. Use a conservative fluid strategy and monitor for any signs of fluid overload. Preventing complications. Pressure injury. Prevention. Regular repositioning helps avoid pressure injuries, especially for patients on prolonged mechanical ventilation. Infection control. Maintain strict infection control practices, as ARDS patients are highly susceptible to secondary infections. DVT prophylaxis. Immobility and a hypercoagulable state increase the risk of deep vein thrombosis. Use compression devices or pharmacologic interventions as needed. Key learning point 4. Nursing care centered on respiratory support, infection prevention, and meticulous monitoring can improve outcomes for patients with ARDS. Medications and therapeutic interventions for ALI and ARDS. Several medications and therapies support the patient's respiratory function and help address complications of ALI and ARDS. Antibiotics, if the underlying cause is an infection. Early broad-spectrum antibiotics help control the disease and reduce systemic inflammation. Sedatives and neuromuscular blockers. Sedatives and, in some cases, neuromuscular blockers can reduce oxygen demand and improve patient comfort on the ventilator. Corticosteroids, although controversial, corticosteroids may be used in certain patients to reduce inflammation and improve oxygenation, especially in the proliferative phase of ARDS. Vasopressors, in cases where hypotension occurs due to systemic inflammation. Vasopressors such as norepinephrine help support blood pressure and maintain organ perfusion. Conclusion. In conclusion, ALI and ARDS are critical conditions requiring prompt recognition and intensive nursing care. By understanding the pathophysiology, assessing risk factors, and performing meticulous nursing assessments, you can improve patient outcomes. Key takeaways include the importance of early intervention, continuous monitoring, and optimizing respiratory support for patients facing ALI and ARDS. If this video was helpful, please like, subscribe, and hit the notification bell to stay updated with our latest content on Wally's nursing videos. Thanks for watching, and see you next time.